focusing today on number 3, expanding access to pulmonary rehab in rural areas. Next. I've been at this for 6 or 7 years now, and some of you much longer, but thinking about this, I sort of stepped back. Okay, Allison, take care. I found myself stepping back and saying, what really are we doing with pulmonary rehab? Because the AACVPR model in some ways is so complicated with so much documentation that sometimes I feel like we get lost, the forest get lost for the trees. So basically, pulmonary rehab is primarily in person, and fortunately, we have the very well defined AACVPR model, which we have followed. But pulmonary rehab is also done in the home, and it's, as we have discussed earlier, it's been around the world. There's a lot of precedent for in-home remote pulmonary rehab, especially in rural areas like Australia and Canada, and even in the United States. Next. Pulmonary rehab, at the heart of pulmonary rehab is exercise. We always say exercise and education, but what do we mean, education? It's learning about my lung, as a patient, it's learning about my lungs and how they work and how they are closely aligned with my heart, learning about what are lung diseases, and then learning what are the treatments, pharmacologic and non-pharmacologic, for pulmonary rehab. It's personal coaching, usually by a respiratory therapist, but sometimes by an OT or an RN, or an exercise physiologist, and the people here know how important that part is. And then it's group support. So to me, that's the real heart of what's going on in pulmonary rehab and leads to its success. Next slide. And also, because we as a group have been talking about different types or different approaches to pulmonary rehab, I just really want to emphasize to our group that there's not 3 different pulmonary rehabs. There's one pulmonary rehab. And the fundamentals are the same for all of those, whether it's the in-person traditional, in-home, or this group has talked a fair amount about the Inspiration Point NIH study that Cheryl Flynn has been doing with her Blue Marble. And regardless of which one of these we're doing, patients still need an intake with a 6-minute walk test and finish up with a 6-minute walk test. And we are doing that in person. They need an ITP, they need orders, they need referral. So particularly with respect to the Inspiration Point study, we still need to have those basic things, including physician referral and orders, and ITPs at the beginning and every 30 days. So let's not lose sight of that. Next slide. Why do so few people get pulmonary rehab? And just before this talk, I took a look at one of the sources, which is Annals of the American Thoracic Society, January 2019, Spitzer et al. They looked at 220,000 patients, Medicare patients admitted for COPD in 2012. They didn't publish this till 2019, but 220,000 patients admitted with COPD. Of those, 1.9% had received some pulmonary rehab within 6 months of their discharge. So there's various measures of how little pulmonary rehab is arriving at the people who need that. Quickly, why is that? We know there's very poor reimbursement by Medicare and commercial. Because there's very poor reimbursement, many hospitals and especially primary care practices choose to not do it. Because they're not doing it, because they choose to not do it, there's less availability, especially in rural areas. Because it's not available, primary care providers like me over many years hardly were aware of it and didn't refer people for it. It's really a big commitment for patients in terms of travel, expense, having to change habits. And also 24 sessions over 12 weeks takes a lot of self-discipline and motivation. Not everybody has that. These patients have comorbidities like congestive heart failure, diabetes, coronary artery disease. They're going to doctor visits. They're in and out of the hospital. That's another barrier. And then the pandemic we're in curtailed the in-person pulmonary rehab that was happening. Next slide. The Appalachian Pulmonary Health Project, Grace Ann Dorney Pulmonary Rehab Centers have been working during this time to expand home-based PR because with the pandemic and reluctance on the part of facilities to be doing in person and reluctance on the part of patients to come in, there's been a big fall off, at least from what we can see, in pulmonary rehab. And so it's made it more important than ever to figure out how to do home-based PR and to start doing it. And this group, on April 20th, at our ECHO session on April 20th, was when Grace Ann Dorney and Cheryl Flynn first told us about a web-based telehealth app for pulmonary rehab, Blue Marble app. And since then, many of us have been working hard to get our hands on it, learn how to use it, and begin offering it to patients. And in a minute, I'm going to show you an overview which might make us feel kind of bad at how little progress we've made, but I would say this is at least a glass quarter full, and we have started, and I'm determined that we keep going. 3 organizations, 4 sites have signed a master agreement and so the RRTs have the Blue Marble app in their hands. 2 more organizations are in talks with Blue Marble for the app. That's Roan General and Preston Memorial. And 2 sites have active patients actually using the app for home-based PR. Next slide. Here's the overview of where we are as of just a couple weeks ago, and there's a few cells that I don't have information on. There's an awful lot here, but you all will recognize the 8 organization and 9 sites that are part of our APHP and GAD PRC network. And I'm happy to see that 1, 2, 3, 4 of those are represented on this call today. Plus we have Aaron Erb, and I think it was, is Stacy, did you say Zanesville? Stacy Stewart?
Yes, I'm with Zanesville.
Great. Is that Ohio?
Yes.
Great. So we are
the
really
Genesis
happy.
Black Lung Clinic.
Great. So Black Lung Clinics. And that Black Lung Clinics is another topic, and we have Krista Mestel with us because of that. And the Black Lung Clinics are interwoven in this effort. So if you look at line 8, you can see in bold there are 4 yeses there. Those are the sites that actually have Blue Marble app in their hands. If you look at Blue Marble app users, it's so far pretty few, but we're really hoping we can expand that. And I think this gathering will help. If you look up at line 4, there is in-person pulmonary rehab activity going on. And it's interesting, it's especially at the hospitals, but Brandy has 5 active patients at Southern West Virginia, Lincoln, Hamlin, Jackson has 5. Big Sandy really hasn't got any pulmonary rehab going on, but they're planning to start again, Krista, because they know it's a requirement of their Black Lung Clinic grant, and they're working on getting that going. So there is in-person pulmonary rehab activity, but it's quite a bit less than what even these sites say their capacity is. If you look at the bottom, across the bottom, I put what was the COVID incidence in those counties for those sites at the time of this. Of course, you all know that that's changing week to week, and generally it's trending down in our region, thank God. But we're all still above the 25 level, which makes us red on most of the maps other than the West Virginia map. Next slide. So what does it take to do home-based pulmonary rehab? And I'm going to show you a slide of what does it take for the patient, and then what does it take for the team, the site team. And in both cases, my comment is it takes a lot. And I think that's what's made it hard to get this airplane up in the air or this kite off the ground. It's a lot of work. And Aaron just put a chat. Has there been any talk about Medicare insurances allowing pulmonary rehab for COVID patients? And Grace Ann, if you would, you're probably more likely to know that than anybody. So hold on to that one for discussion. We know that, well, I'll get to the fact that CMS is permitting telehealth pulmonary rehab. So what does it take for a patient? Well, first of all, the patient has to decide, yes, I want to do that. That's an important step. Tobacco cessation isn't required, but let's not forget that as part of pulmonary rehab. They have to complete the traditional intake like we do for every other patient. I see your chat, Brandy, thanks. So they have to do their 6-minute walk test. They have to do their standard intake. We need a physician to sign orders. We need an ITP. Then they have to have a compatible device where they can run the Blue Marble app, and they have to have internet access. And not everybody has that, especially in rural areas. But let's bring this to the people who do. If they can do online shopping with Amazon or any other app, they can do this. They have to be able to successfully download the app to their device or receive a preloaded loaner device. And with many of our patients, this has been in some ways the most difficult step because older folks, rural folks, are not necessarily as tech savvy to be able to do this. So there's been a lot of work helping people to do this, so much so that both Cabin Creek and New River are right now purchasing Kindle Fire devices that we are going to preload so we can loan it to the patients. That's been available for study patients, but we want it for our general population. Then they have to learn to use the app. And our RT coaches are helping them with that. Our respiratory therapists are helping with that. We can do that over the phone remotely. Then with their coach, their respiratory therapist, just as they would an in-person pulmonary rehab, they have to establish a daily or at least 3 times weekly routine of exercise, studying lessons, and doing assessments. And doing assessments means doing their daily COPD survey, also known as action plan. And in many cases, we have them using the COPD assessment test, the CAT, as part of their daily routine. And when they do that, then that's logged in the cloud on the Blue Marble app, and the respiratory therapist can see that and can see what they're doing and if they're keeping up on their program. They have to attend weekly telemedicine pulmonary rehab visits with their RT coach. And those are billable visits, and we're working with our RTs to do remote telehealth billing, which is a new thing for them. Then they have a traditional graduation with their 6-minute walk test and completing their various questionnaires. I'm talking about not the study here. I'm talking about regular home-based pulmonary rehab with our general population patients with COPD, interstitial lung disease, black lung. The study is only limited to COPD. This is with all chronic lung disease patients. And finally, we want them to establish and follow a long-term maintenance plan with their RT coach and to keep on using the app for that maintenance. The app is a powerful tool for maintenance and long-term care and care coordination. And then we want them to attend a monthly Medicare chronic care management visit, billable as a chronic care management visit by telehealth. Or actually, this doesn't depend on emergency telehealth. This has been available all along. And again, doing this is a really new thing for our respiratory therapists, and I'm calling them RT coaches. So there's a lot of learning curve for the patient and for the team. Next slide. Here's what the patient sees when they log into their Blue Marble app. This is the front page, the activities page for a patient who's logging on to their app. And if you look at the top, you can see it says activities, and that's the screen they're on right now. Then there's a place for their records where they're keeping track. There's a diary where they can record when they went to the doctor, what tests they've done. And then there's a place where they can set their own goals. Then down here in the middle, you see that there's a COPD action plan survey. They click on that and ask a series of 16 easy questions. And based on that, it generates an action plan for them. And it also rates them as having a red, yellow, or green day, which their respiratory therapist can see back home at the center on her dashboard. And then the things below this are assigned by the RT. For example, their CAT. The thing that says intermediate 01 is an exercise plan that the RT and the patient has developed together. Down at the bottom, you can see the 3 blue buttons: tests, exercises, and lessons. So this is where the patient can go to the full library of tests and exercises and lessons to be doing their study, to be setting up their exercises and documenting those. Next slide. What does it take for the team? It takes a lot. First of all, our respiratory therapists and our physician champions have to have the app and learn to use it. And partly this means putting yourself in the shoes of your patient and making yourself a test patient and signing in and walking through what the patient has to do. You got to do that to be able to work with the patient. You have to actively recruit patients in the organization. We cannot just wait for referrals from within we know referrals in our organization are still not great. Our primary care providers are busy. They've got patients who have 5 or 6 chronic conditions and a med list of 10 to 20 things, and they're still not thinking of pulmonary rehab routinely. We've got to go to them. And we are doing that at New River and Cabin Creek. We estimate, and so now we're finding in the patient's practices or in the provider's practices, we're finding all the patients who are eligible. And we're having a personal letter go from their provider to them offering this, and then we're following up with a phone call. We think that about somewhere between 1 in 10 and 1 in 5 patients who we identify as needing pulmonary rehab will say yes. But all our practices have hundreds of patients. So even that low level of saying, yeah, I want to do that, there's still plenty of patients that we can have in pulmonary rehab. And we know from our experience that of the ones that start, about half will graduate. But Grace Ann mentioned to us the last time that a recent study of people starting COPD with exacerbations that showed that even 3 episodes of pulmonary rehab led to improvements in survival and quality of life. So they don't have to graduate to benefit. We just need to get them in. The RTs need to learn to use the administrative side of the platform, what Cheryl and her group call the PAT account. This is another thing that is a lot of work. There's a real learning curve for this. You learn to create activities, activity schedules, and assign activities to the patients, and I'll show you the dashboard for that in a second. We need to complete the standard intake and the orders and the ITP, and get medical clearance, like I emphasized before. They need a weekly telemed G0424 visit, so we need to provide that. We need to do their standard Q30-day ITP. We need to do the standard graduation. Please remember to do your CAPGATE data entry. We haven't paid much attention to that in the past year, but we are going to be coming back to you about that. And finally, we need to establish a maintenance plan with the patient. There's a lot to do, and there's a lot to learn. Next slide. Here's what the dashboard looks like for the RT, who's the coach for all these patients. If you look at the very top, you see that there's a user dashboard, and that's the view we have right now. Then there's a list of their users, who they are. Staff refers to that in organizations where you have multiple RTs and multiple panels of patients, the administrator for this account can assign certain patients to certain staff. Otherwise, all staff see all patients. Creating and editing activities is where you set up a personalized exercise plan for the person. Then you assign that to each of your patients. Then you create an activity schedule. Then you assign it. And I'll show you what that looks like in a second. Then down here, you can see that for each patient, and most of these patients are test patients, like here's Carrie Cashin, our RT at New River, in her role as a patient. It shows when they last logged in, how much time cumulative have they spent on the app, what test results do we have on them, and then their action plan. And you can see here in the action plan column, it shows whether people are having a red day, a yellow day, or a green day. And as you know, the American Lung Association adopted this action plan approach from the asthma action plan model, and it's pretty good. Next slide. This is what the screen looks like. Remember a minute ago we were looking at we had the dashboard highlighted, but if you come all the way over here to assign activities, you see this screen. And so this is where RT coach assigns an action plan. Actually, she assigns, the action plan is something that we can design. We can modify what feedback the person gets, depending on whether they're having a yellow day, red day, or green day. We can assign tests. What are assessments we want the person to do each day? Like, for example, their CAT, or a balance test, or a PHQ in terms of depression. There's about 10 or 15 different tests that can be assigned. And finally, there's that all important exercise plan. Daily exercise, or at least 3 times weekly exercise, is the heart of pulmonary rehab, along with the lessons, the self-study. So this is what the RT uses to assign that. Next slide. And this is just a reminder that telemedicine pulmonary rehab is reimbursable during this emergency period. We hope and pray it will be expanded beyond the emergency period, because home pulmonary rehab really is a way of expanding this to people who couldn't get it otherwise. I'm going to end with that and let people speak up. A number of you have things to say, and actually I would like to ask Grace Ann and Cheryl to start, not necessarily in that order.
Since this is your baby, Cheryl, I will defer to you.
Thank you. Thank you, Dan. You did a great job providing that overview, and certainly any feedback that anyone can give us in terms of making this easier any along the way in terms of learning how to use it, or on the patient side, we are very open to receiving that feedback. One thing, Dan, that I was curious about, you mentioned something called CapGate, and there's data entry required for that. And I was wondering if potentially the platform, if it's collecting that data, could we not just use an API to send it directly to your database, and then the person, whoever is doing that data entry, doesn't have to do that? So we could make that automatic if the app is collecting the data that you're talking about.
Great suggestion. I'll make a note and we'll follow up on that.
Okay.
It wouldn't get us, it would get us our home pulmonary, but anyway, that's a great idea of trying to coordinate different data systems.
Yeah, because I know that there is a learning curve to get started, but really the goal is to make things a lot easier for people in the long run, and receiving that data and being able to manage your patients a bit easier, and certainly for them to be able to manage their disease better. So I guess I'll leave it at that. I'm happy to answer questions if Dan isn't able to, or Grace Ann.
This is Grace Ann. I would only add that at this moment, it's really not clear what the reimbursement rate will be. It was anticipated. It's been anticipated for the last 2 months. And I'm participating in pulmonary rehab working groups at ATS. And as soon as I have an answer on that, I will send it through to, I guess not Mithra anymore. I guess I would be sending it to Elizabeth Minnick. But I will get that information for you. I mean, they've been extremely slow in setting rates. So that is something of a handicap. And I did see Sam's comment in the chat. it's not clear. Institutions and larger hospital systems have been working on this differently. It's really not clear as to what reimbursement there would be for COVID patients. But I believe if you could show with PFTs and symptoms and other data like CTs, which I'm sure they got in the hospital, that they would be eligible for pulmonary rehab. I don't see why. And the time to get them again is within at least 90 days of hospital discharge, because Peter Lindenauer's study was based on 2,000 in the CMS database who received pulmonary rehab within 90 days of discharge. So, I mean, clearly the sooner you can get someone into a program, the better. And that did show a significant mortality benefit. So I will keep you posted when I learn something more. I have a meeting next week, and I'm hoping that they will have answers then.
I'll also just mention on the COVID topic that our platform is being used in an NIH study for COVID patients at University of Colorado, Denver. And instead of using the COPD education modules that you all have probably looked through in the app, we created a similar set of education modules, and it references lung health as opposed to COPD. And we took out some of the information that was very specific to COPD and made it a little bit more generic. And we worked with the team at Colorado to make those education modules. So if anyone wanted to or was interested in trying this out with people who are recovering from COVID, there is an optional education module that you could use.
Cheryl, this is Grace. And again, did you work with Barry Make on this?
At Colorado?
Yeah.
No, I worked with Christine Erlinson.
Yeah.
And then some of the folks from their, the physical therapy program is actually running the study.
Okay.
This is Sam Giordano, and I just wanted to comment, to follow up on the on what we discovered with the Lindenauer manuscript. And it's a twofold problem. Certainly, reimbursement, as we learned many, many years ago, no bucks, no buck Rogers when it comes to healthcare. So care does follow the dollar, and we have to address the reimbursement issue, get it resolved once and for all. We've been pecking at this problem for over 20 years. But the other side is the demand side. And this is where I think RTs and others could play a role as essentially advocates and salespersons for this clinical intervention. I'm a little older than I like to admit, but back in the 60s, respiratory therapists, or as we were known then, inhalation therapists, had to actually go out and sell physicians on the clinical interventions we had available in our department. We were not getting orders for even simple things like aerosol. So we undertook, we got studies, and we spoke at medical staff meetings. We became salespersons for the clinical interventions that we were able to provide. And when you look at you can say, well, a lot of people didn't have access to pulmonary rehab programs, but what about the part where the attending physician is not referring the patient to pulmonary rehab programs? And I realize it's a chicken and egg thing. Some could say, well, we don't have any in our area, therefore I'm not going to refer them. But on the other side, if we don't seed demand for this service, new programs will not come up. And even if they're not there, now that we have these wonderful platforms where pulmonary rehab programs can be done in physician offices and in the home, I think it's all that much more. We should redouble our efforts to advocate for more referrals, as well as we, alongside of our advocacy for appropriate reimbursement. Here endeth the sermon. Sorry to go so long.
Thank you so much, everyone. Were there any other comments or questions for Dr. Doyle or Cheryl or anyone?
I know we're just about out of time, but I'd still like to get Krista Critchfield to move about 12 inches to her right. You know, you have been in the middle of trying to get this to patients and get patients signed up, Krista. And Lauren or Mitra, would you put back up the slide about what does it take for the team? What does it take for the team? And I'd just like you to comment on what you see here, Krista, and what have been the biggest challenges for you? Right there.
Okay. Well, I just think the biggest challenges for me is one, finding the patient that, you know, is going to use it. They have to be motivated. I'm looking for a woman probably in her 60s that can shop on Amazon and does Facebook, because a lot of people are just scared of technology in this area. So that's one hurdle. The other hurdle, I think, has mainly been just getting the app on a device. So that's the two hardest parts, you know, and keeping them motivated, of course, to get through all this. It's a lot of intake and stuff, but I'm determined we're going to do this because I really think this is the way pulmonary rehab is going to go.
Great, thank you. And I would say, you know, there are a number of respiratory therapists on this call that are trying to do this. And in some cases, it really takes intervening with their organizations. You know, Sam, you mentioned about getting to the primary care providers. I totally agree with that. I think we have to be very proactive about that. In some cases, the organization's administrative leadership is discouraged by no bucks, no buck Rogers. They're also slammed by the pandemic and have had to furlough staff. And so it's a real challenge to capture RT time to work on this. Many RTs are out in parking lots doing COVID testing, a significant part of several days a week or every day. They have other duties. Some of them are doing hospital work as well. So there's a big challenge for us to find physician champions within organizations who will work with their RTs and work with administration and find dedicated time for them to work on this. But there are people here like Terry Hauser and Tara Morris at Preston, like Aaron Erb at Armstrong, like Krista and Carrie Cashin and Lisa Emery, let's see, I think I already mentioned you, Brandy. Johnny's not with us. Who are trying to do this and want to do it, and we need their support so they have time to do it. Or they need our support so they have time to do it. So you can take that slide down, Mitra, and wrap it up.
Absolutely. Thank you so much, Dr. Doyle. We can't thank you enough. Before we part ways, did anyone else have any comments, questions, thoughts that you wanted to share with the group?
This is Grace.
Well, yeah, I have one more thing.
Oh, okay, go ahead, Dan.
Go ahead, Grace. Go ahead, Grace Ann.
I was just going to ask Tara Senza, who joins us today from Northwest in Randallstown, Maryland, if she has any observations, because this is the first time she's attended.
Hello. Thank you so much for the invite. I really enjoyed listening to this. Pulmonary rehab is something new to me. We're still closed due to COVID. So I'm just taking this all in, and we're trying to be up and running, hopefully sooner than later, preferably by June. So I just appreciate all your insight.
And I want to thank you, Sarah. It's great to have another motivated respiratory therapist who's trying to do this with us. And I hope you keep coming back to these echoes. And I just want to thank Cheryl and her staff, especially Will Pooh, who have been amazingly available to us. I mean, we can almost get on the phone and call them up anytime, day or night, and they are there. It helps that they're 3 hours behind us, so because they're still in the middle of their day when our day is just about ended. But they have really, really helped us with this app. I think that if it weren't for their willingness, we couldn't have made the little progress that we have. So thank you very much, Cheryl.
You're welcome. Our pleasure.
All right, and Cheryl, I just realized it's probably like 5 a.m. over there, so we really appreciate it. Thank you. And Grace Ann, I will still be here, so any resources you need to email my way, I can certainly distribute it to the group as well. So, all right, well, thank you so much, Dr. Durrell. That was really wonderful. Just a quick announcement, our next session will be on February 15th, and Dr. Stansbury is going to discuss central versus obstructive sleep apnea. Keep an eye out for that reminder. And I look forward to seeing you all next time. Stay warm. Bye.